morning, everybody, and thank you for joining us today for the launch of our book, Aging with HIV in Sub-Saharan Africa, Health and Psychosocial Perspectives. My name is Mark Brennan-Ing. I'm the Director of Research and Evaluation at the Brookdale Center for Healthy Aging. We're very pleased that we have a number of our authors here as panelists. Some are joining us on Zoom from South Africa and Australia and France, and we also have some of our authors here in person for the panel discussion. So just briefly, our agenda today. The managing editor of this book, Kristen Porter, Dr. Porter, is going to be giving us an introduction. Then we're going to be having a panel presentation by the authors, where the authors will be talking about the major findings from their work and the implications for policy. And then we're going to open it up for a discussion and Q&A time. And then for those of you lucky enough to be here in person, we have a little reception afterwards. So let's hear from Kristen Porter.
Welcome, and thank you for joining us to celebrate the publication of Aging with HIV in Sub-Saharan Africa, Health and Psychosocial Perspectives. My name is Kristen Porter, and as a co-editor of this book, I would like to offer my congratulations to all of our contributing authors. We span 6 countries over 4 continents, and publishing a book about one pandemic during another pandemic is no small feat. While here in the US, over 1 million people with HIV are age 50 and older, which is truly a testament of successful HIV treatment, but so much less is known about the 4 million older adults with HIV in Sub-Saharan Africa. We wrote this book to bring greater attention to this often invisible yet growing number of older people with HIV in the region. Although the preface of this book provides greater detail, the genesis of this volume goes way back to 2012, when Stephen Karpiak and Mark Brennan-Ing were research directors at the AIDS Community Research Initiative of America, or ACRIA. And they were working on the seminal ROA study, which was the research on older adults with HIV study. Through numerous connections, ROA Africa was launched in Uganda in collaboration with our co-editor, Janet Seeley and colleagues, and then in South Africa in collaboration with our co-editor, Catherine McVeigh and colleagues. In 2015, I began a postdoc with Mark, and then in 2016, while in Durban, South Africa, at the International AIDS Conference, Janet, Catherine, Mark, and I met to talk about ways that we could disseminate these data. Our goal was to include research representing the different regions of the continent, and authors in this volume work in West, East, and South Africa. The chapters present a range of methods and cover topics including epidemiology to the impact of comorbidities, mental health and cognitive functioning, perceptions of illness through the lens of the HIV epidemic, managing stigma, countering the myth that older adults are not sexually active and therefore not at risk for HIV, grandparenting and other caregiving from a population who also needs care, social support resources, HIV service provision, and policy recommendations, all written by both established and emerging scholars in HIV and aging. While these chapters shine a light on many challenges that are faced, they also give voice to the resilience of a population that has managed to survive and often thrive into later life. It is to these older people with HIV who this book is dedicated, along with Dr. Stephen Karpiak, who predeceased its publication. While our limited time today did not afford us the ability to feature every chapter in the book, yet another reason you'll want to grab a copy. We do have 6 panelists with us today who will share major findings and implications from their chapters. We really appreciate your reflections and questions, so we're going to look forward to an engaging Q&A with you after the moderated discussion. And speaking of, it is a great honor to introduce you to our moderator today, who I am also lucky enough to call my mentor and friend. Dr. Mark Brennaning, Director of Research and Evaluation at the Brookdale Center for Healthy Aging at Hunter College, the City University of New York. Dr. Brennaning's research focuses on psychosocial issues affecting persons living with HIV and older sexual minority and gender diverse adults. They are past president of the State Society on Aging of New York, a fellow of the Gerontological Society of America, a fellow of Division 44 of the American Psychological Association, and past board member of the New York Association on HIV over 50. Please join me in welcoming Dr. Mark Brennaning.
Thank you, Kristen. It's really been a pleasure working with Kristen and all my co-editors. Someone new to that team is Jenny Kaufman, who's a senior research associate at the Brookdale Center for Healthy Aging, and was really instrumental in helping pull this volume together. And also, I'm very indebted to Janet Seeley, who was not able to join us today, and Catherine McPhail, to have such wonderful collaborators. And as Kristen said, it's not easy to do a book about a pandemic during another pandemic. We thought, oh, this will be, everyone's at home, everyone's writing, but there were some challenges. But we're so pleased that this volume has finally come out and shedding some light, we think, on a very important issue that's not getting a lot of attention on the global stage. So this is our author panel. I'm going to introduce everybody at the same time. In the promotional materials for this event, there were detailed bios on everybody, so I'm not going to go through that today, so we can spend more time hearing about the work and the research. So first we have Dr. Javier Gomez-Olive. Dr. Gomez-Olive is an associate professor and research manager at the School of Public Health at the University of Witwatersrand in Johannesburg, South Africa. His chapter was entitled The Epidemiology of HIV in the Older African Population. Next up is Dr. Cabo Matlow. He's a research scientist at the University of Sydney in Sydney, Australia, and his chapter was about comorbid conditions occurring in older adults with HIV on antiretroviral therapy in Botswana. Next up is Dr. Charlotte Bernard, a scientific coordinator at the University of Bordeaux, Bordeaux Population Health Research Center in Bordeaux, France. And Dr. Bernard is going to be talking about mental health in older adults living with HIV in sub-Saharan Africa, state of the art and future. Next up is our co-editor, Dr. Catherine McPhail. Catherine is an associate professor of public health at the School of Health and Society, University of Wollongong. I'm sorry, I'm so bad with Australian names, in Australia. And she's going to be talking about her chapter, The Support Keeps Me Strong, Social Support Among South Africans Aging with HIV. Next, we're very pleased to have here in person Dr. Jepchirchir Kiplagat. Dr. Kiplagat is from Moy University. She's the Moy University Research Program Manager at the Academic Modeling Providing Access to Healthcare AMPATH program in Eldoret, Kenya. And we're very pleased that Dr. Kiplagat can be with us in person today. And last and certainly not least is Dr. Ruth Finkelstein, who's the Rose Dobroff, Director of the Brookdale Center for Healthy Aging at Hunter College. Ruth is going to be talking about Beyond Policy Fixes to a New Politics of Care, the case of older people living with HIV in sub-Saharan Africa. And I just want to, as an aside, Ruth gave us tremendous support during this project, and that was most appreciated. And I also enjoyed working on this chapter with her. So each person is going to have about 5 to 7 minutes to speak. We're going to hold questions until all of the panelists have presented, and then we'll have some Q&A. So first up, Dr. Gomez-Olive.
Thank you very much, Mark. As he said, the first chapter is the epidemiology of HIV in all the African population. In this chapter, I describe how the epidemiology of HIV has impacted the older population who have directly suffered from the consequences of the HIV deaths in their families, have carried the burden of looking after an orphan generation, have been stigmatized, and still they have been ignored on the HIV prevention and treatment campaigns. The introduction of ART in early 2000 and the universal test and treat approach in most African countries have been linked to a higher survival of people living with HIV and to the advent of the first generation of people with HIV over 50 years of age. At present, although growing, there is still a dearth of literature on HIV in all the population. Some numbers of the HIV epidemic in this older age group that I present in the chapter, some authors have estimated that from the year 2000 to 2016, the HIV-infected population 50 years and older has doubled. In 2016, Africa was home to nearly 4 million of the estimated 5.7 million people over 50 living with HIV worldwide. It is expected that by only 20 years from now, 1 in 4 HIV-infected people will be 50 years and older, and 2/3 of them will be living in Central, Southern, or Eastern Africa. However, still only a handful of countries include population 50 plus in their national reports, and when they do, the reports repeatedly prove that the epidemic is definitely aging with higher prevalence in older people than in younger people in some areas. Contrary to general beliefs in Africa, older people are sexually active and at risk of HIV infection. However, older people are unaware of their risk and they present high sexual risk behaviors as young people do. In relation to incidence is higher than expected in these older age groups, but still there are very few studies that have focused on this issue and more data is needed. It is therefore crucial to include older people in HIV/AIDS prevention awareness and treatment campaigns. HIV mortality trends in this older population. Reporting on AIDS mortality has been a difficult task as most countries do not have a proper mortality report system, or when they have, like in South Africa, the stigma has prevented HIV disclosure as a cause of death. For example, initial estimations of HIV mortality in South Africa moved from under 3% to 48% after correcting for misclassification. HIV-related mortality in Africa has increased since the beginning of the epidemic, with a peak of mortality in 2004. The introduction of ARTs in 2010 led to a reduction of mortality by 38% by 2019. However, this mortality reduction mainly benefited the young population, increasing the gap between older and younger age groups in terms of gain achieved from the response of the HIV epidemic. In Agincourt District, for example, in Northeast South Africa, data from 20 years of follow-up showed that in 2011, HIV/AIDS was one of the main causes of death for 50 to 64-year-old and was an important cause of death even for those over 65. HIV in this area was the reason that the population in their 50s and 60s had higher mortality rate than those in their 70s. In addition, a study analyzing ART programs in 9 different sub-Saharan countries showed that despite the introduction of ART, excess mortality associated with HIV infection was higher among people 50 years and older than in younger age groups. In this chapter, there also discusses the effects of the epidemic is having on the caregiving responsibilities of all the people. Traditionally, people in Africa would expect that they will be looked after once they arrive to an older age. However, the HIV epidemic has placed them as caregivers with a high responsibility of caring for those infected of HIV in their families. The introduction of non-contributory old age pension in some countries has given older people a position of power, becoming the breadwinners in the family. However, this income has been used in many instances to support their HIV orphan grandchildren. Moreover, the introduction of ART has increased the survival of grandchildren living with HIV, and mainly grandmothers now need to monitor their treatment, general well-being, and social integration. In relation to the giving of all the population, there are some questions discussed in the chapter that need further research. For example, who will look after the older people when they become frail and they kind of look after other people? Who will take care of them when they need to take different medications and their cognition starts to decline? Who will help them cope with the new problems that their now adolescent orphan grandchildren will bring to their lives? Getting older with HIV puts this older population facing many challenges to placing themselves in a strong position to prevent new infections and receive antiretroviral treatment in time to save their lives. Older people are increasingly suffering from other chronic conditions related to the aging process. In this situation, they will present with multimorbidity and suffering from the double epidemic of HIV and communicable diseases. To conclude, let me read the conclusion of the chapter with some recommendations for policymakers and policy implementers. The HIV epidemic is aging in Africa, creating the first generation of older people living with HIV. In the next 20 years, the percentage of older people living with HIV may triple in the continent. This new situation may have serious implications for the health of those 50 years and older who also suffer from age-related diseases like dementia, cognitive impairment, frailty, and non-communicable diseases. In this context, where older people are experiencing high levels of multimorbidity, it is crucial that health and social systems prepare holistic and integrated care for all the patients. Moreover, policymakers should provide new guidelines to promote HIV testing, treatment, and follow-up among older people presenting in primary healthcare facilities, seeking treatment for their non-communicable chronic conditions. Finally, it should not be ignored that older people are suffering different levels of stigma in relation to HIV and that support programs should be organized. Thank you very much.
Thank you, Dr. Gomez-Olive. I think that really helps set the stage for the talks that are to come by providing the context. Our next speaker is Dr. Cabo Matlow. Cabo, please. That's fine. You could just start from the beginning, please.
Okay, just from the beginning. Okay, good morning, everyone. Mine is chapter 2, which I wrote together with Joel Megan and Madeleine Rendell. It's titled Comorbid Conditions for Caring in Older Adults on Antiretroviral Therapy in Botswana, which is a retrospective cross-sectional cohort study of patient data. Just recently at the AIDS conference in Canada, a recent national survey from Botswana indicates that Botswana has achieved the UNA's 95 targets for people living with HIV. Among all people with HIV surveyed, about 95.1% of them were aware of their status, and 98% of those people were on ART. And of those on ART, 97.9 achieved viral load suppression. Yeah, with a total national prevalence of approximately 21%, which is indicative of the success of the Botswana HIV program. While Botswana is tackling the changing patterns of HIV infections and associated mortality and with great efficiency, it tends to emphasize specific demographics, like pregnant mothers, young people, people of reproductive age. Even in the recent survey, the target population was those aged between 15 and 64 years old. ironically, which is the cut point at which one is eligible to receive old age pension in Botswana, which you get at 65 and above, officially being regarded as old. So its management of HIV often overlook older adults as a subgroup of interest. According to the recent statistics, the proportion of older people, those 50 years and above, living with HIV in Botswana has, however, markedly increased. This growing cohort faces increased risk of chronic illnesses, age-associated diseases, making their comprehensive care a matter of urgency. In light of this increase in population and the projected rise in associated non-communicable diseases, however, a long-term strategy aimed at optimizing the holistic and comprehensive treatment and care for these older people with HIV is crucial. Engaging and understanding the potential health implications of the co-occurrence of acute and chronic illnesses in this cohort is very important. It is an essential part of this strategy because as more people grow older and stay alive, the chronic care and management of challenge, the chronic care and management challenges will also grow. Our research therefore looked at the prevalence of comorbidities among older adults living with HIV in Botswana, in particular estimating the prevalence of comorbidities within an HIV cohort in Botswana using the data from patients aged 35 years or older or on antiretroviral therapy from selected infectious diseases care clinics in the greater region of Gaborone in Botswana. The rise in the prevalence and increase of risk comorbidities, diseases such as diabetes, dyslipidemia, and cardiovascular disease has actually previously been reported in the general HIV population in Botswana and other countries in sub-Saharan Africa. However, our study was the first of its kind to examine HIV and comorbidities in the context of aging in Botswana. The results pointed to a growing presence of comorbidities in older people living with HIV, thus supplementing and adding to the existing literature globally that people aging with the infection exhibit vulnerability to multiple health problems. It also underlined age as an important distinction, with the older cohorts having higher odds of developing comorbidities than their younger counterparts in the study. This observation was consistent with prior studies that have reported a higher presence of multiple morbidities in older individuals with HIV compared to their younger counterparts as well as people without HIV. It was also clear from our study that gender had some role in comorbidity predisposition, with older women specifically more likely to be affected than older men. This observation was aligned with research in other parts of sub-Saharan Africa that have reported high rates of morbidity in women living with HIV in sub-Saharan Africa. While we did not find a strong association between the presence of comorbidities with HIV treatment in the study, prolonged exposure to ART treatment, lower CD4 counts, and higher viral load have in literature been linked to some disposition to comorbidities. So in summary, while aging is not going to be a problem that is unique to Botswana, the aging HIV population has unique needs. HIV testing and prevention, messaging, specific linkage and continuity of care needs, long-term ART and side effects, including renal failure, bone densities, propensity for developing advanced diseases and complications if treatments are interrupted, and also non-HIV related chronic disease management, polypharmacy, frailty, neurocognitive impairments, and mental health needs, and over-reliance on others at a social level for basic care and health needs. So in conclusion, it has become abundantly clear that Botswana needs to recognize its systems. Botswana needs to reconfigure its systems to strengthen the clinical care and put in place appropriate structures and policies that address the challenges presented by the success of its HIV treatment intervention. There is a need to disentangle the complexities of HIV and aging and address the multifaceted issue of comorbidities following the success of the treatment-based outcome. A long-term strategy, I guess, and perspective aimed at optimizing holistic and comprehensive treatment and care for older people living with HIV is essential. And close monitoring of chronic illnesses in these individuals is recommended if we are to improve their quality of life. Thank you.
Thank you, Dr. Matlow.
Thank you.
And our next panelist is Dr. Charlotte Bernard.
Good morning, everyone. So I'm pleased to say a few words about the chapter entitled Mental Health in Older People Living with HIV in Sub-Saharan Africa that I wrote with my colleague Nathalie de Reckner. And I would like to thank Mark and Kristen for giving me this opportunity today. So this chapter focuses on depression and cognitive impairments, which are among the 3 most common mental disorders in this population. And these disorders have consequences on care and HIV response that should not be neglected, particularly non-adherence to antiretroviral treatment, poor health status, but also poor HIV outcomes and mortality. And they also impact daily activities and the quality of life of the patients. So addressing the mental health needs of older people living with HIV is critical to accelerate progress towards UNAIDS 395 targets. So the aim of the chapter was to provide a general overview of the morbidity experienced by older people living with HIV in this region of the world, focusing on depression and cognitive impairment. And it was also an opportunity to discuss for further research and recommendations. So regarding the epidemiology of this disorder in this population, we have observed that it is difficult to have a good image of the reality, including for the determinants of these disorders, because data are reported are specifically, data in people living with HIV age 50 years and older are very scarce. The majority of the studies include adults with a wide range of ages, but a limited proportion of people aged over 60. And we also highlighted the need for harmonized and accurate tools. Regarding depression, we know that the diagnosis could be difficult as older patients, HIV patients report more easily somatic symptoms than emotional or affective ones. And regarding cognitive impairment, cognitive performance tests have been developed in Western countries with a large majority of the population as a high literacy level, and therefore they are not specifically adapted to sub-Saharan populations. So we emphasize the need to think about cognitive assessment more adapted in routine clinical practice and across cultures, but also the need of normative data based on age, gender, and educational level. Comorbidities need also to be assessed since some of them impact cognitive functioning. And the International HIV Cognitive Working Group also insisted on a new approach to cognitive impairment in PHIV, so this is an important point. In this chapter, we also recommended to build longitudinal cohort studies with several follow-up points to better understand the course of cognitive disorders and depression over time in older people living with HIV in this region of the world. MRI studies experienced with success in South Africa and in Senegal in this population would also be an important innovation to provide an in-depth description and understanding of the physiopathology of cognitive impairment in this population. It will be an opportunity to evaluate similarities and differences with neurodegenerative processes, for example. Another important point that we mentioned in this chapter is that the aging experience for older PHIV in sub-Saharan Africa was not well described. They may experience concerns about disclosure, higher stigma, but also uncertainty about the future. And all these factors could negatively impact mental health. So further studies are needed to better understand the reality of the aging experience in in this population to offer them more comprehensive mental health support. And finally, we also look at psychotherapeutic and cognitive interventions that are available in this region of the world for this population. And we observe that even promising results of psychotherapeutic interventions have been reported in Uganda and South Africa. We need psychotherapeutic intervention adapted to the specific needs of other PLHIV. And concerning cognitive interventions, no studies have evaluated the impact of a cognitive intervention on cognitive impairment in sub-Saharan Africa. But in Western countries, among the different strategies evaluated, one computerized cognitive training has been proposed to be a promising tool for the future. So we need to evaluate maybe that in the African context. So, and in this chapter, we highlighted the need to better understand the epidemiology of these disorders and to propose more adapted psychotherapeutic and cognitive interventions. And describing the aging experience is also a main key point in our point of view. Thank you for your attention.
Thank you, Dr. Bernard. Okay, we will now turn to social support issues. I think this has really been highlighted by the presentation so far, that if you're growing older, if you're dealing with a lot of comorbidities, stigma, and mental health issues, you likely need some kinds of social support, just like anybody else does as we get older. So Dr. Catherine McPhail is going to be talking about social support issues. Catherine.
Thanks, Mark. So HIV and aging in South Africa is driven by two key issues. The fact that the country has the highest population proportion over 50 years of age in Africa, and that it has one of the largest HIV treatment programs in the world. These two factors together have seen an increase in the proportion of people in South Africa who are aging with HIV. And data from 2011 predicts that HIV prevalence among people over 50 years of age in South Africa will double over the next 30 years and have significant consequences for healthcare and for social systems. Previous research into HIV and aging has largely been conducted in high-income countries such as the US, where the epidemic is largely concentrated in men who have sex with men. In this context, the intersection of ageism, homophobia, HIV-related stigma, and the initial high HIV-related mortality resulted in contracting social networks for those who are aging with HIV, and has led to experiences of a lack of support, isolation, depression, and has had implications for medication adherence. But what have been the social support experiences of those aging with HIV in low and middle income countries such as South Africa? We know less about these experiences. In this chapter, we explored social support by conducting interviews with South Africans over 50 years of age who were recruited from a Johannesburg inner city HIV treatment clinic. We spoke with 15 men and women, the majority of whom were aged between 60 and 64 years. All were parents, and many were also grandparents. Most were no longer working, but those who were reported being engaged in low-skill occupations. 2/3 of them mentioned that HIV had impacted their extended families, but few reported taking care of AIDS orphans, despite this being the role that much research has historically focused on among older people. Overall, our participants reported strong social support. All were vehement about not feeling particularly socially isolated. HIV disclosure was universal within nuclear families, and all reported support, particularly from their adult children. Cabello said, "I really thank God for my 2 kids because we really are in this thing together." Few had worried about negative reactions to their HIV status, with most being more concerned about how the news of their diagnosis might impact their family members. Support from family was reported as largely instrumental, that is, practical assistance with daily living or financial. It included reminders about taking medication, providing money for transport to the clinic, and also included assistance with domestic chores and personal care. In contrast to support from family, which men and women reported equally, women were much less likely than men to report support from an intimate partner. Indeed, a key difference between men and women in our sample was that women were much less likely to discuss having a partner at all. More men were married and talked about instrumental and emotional support from a partner. In contrast, for example, Buhle's husband had died of AIDS, and she seemed relieved to be out of an unhappy marriage, but had not had an intimate partner's support since. She told us, "Since my husband passed away, I have not had a boyfriend or been with anyone else, so I'm not getting support from anyone." Outside of the nuclear family, our participants experienced little support. Women spoke of some extended family support, but both men and women were reluctant to disclose their HIV status outside of the family and were therefore not able to get support elsewhere. There were a few exceptions, but most spoke about not wanting to be a bother to others and having concerns about gossip and stigma. A significant finding was the degree to which the participants spoke about their increased support and care roles, despite their HIV. It was not uncommon for participants to snort with derision when asked about the support that they receive, and to make comments such as Lungile, who noted, "It's getting more and more now. The older you get, the more responsibilities you get." Providing support to others, including emotional, instrumental, and particularly financial support for adult children, grandchildren, and other extended family members. Men and women experienced this aspect of their lives very differently. Men's support of others was limited to largely financial support, and most acknowledged that it had remained the same or declined as they aged. In contrast, women's financial and caregiving roles often increased as they aged with HIV. Overall, participants discussed having good or adequate instrumental and financial support, but few mentioned having good sources of emotional support available to them. Women's networks were slightly wider than men's, but they were also less likely to have support from partners and to have large and sometimes growing demand on them to support others. The data presented here should be viewed in light of the South African context. HIV is a disease most experienced among heterosexual populations in South Africa, and participants in this study did not have to overcome homophobic attitudes to retain their social support. Traditionally, South African culture reveres elders, although contemporary work would argue that this is changing, and therefore the impact of ageism may be less than experienced in high-income countries. The continued caregiving role of participants, particularly women, is consistent with other research in the region. Women bear the brunt of instrumental care, no matter their own health, and also have significant financial responsibilities to extended family. In South Africa, access to the government old age pension appears to play an important role in the continued financial support that older people living with HIV provide to their families. Although a modest amount, about $136 monthly, it is a significant safety net for older South Africans and often the only source of household income. This has both advantages and disadvantages. If used to support adult children, it may mean that older people with HIV have other adults living in their households who are able to provide emotional and instrumental support. However, where children are younger and unemployed, or where grandchildren are being supported, access to the pension is likely to increase financial and caretaking responsibilities, paradoxically adding to financial stress for older people living with HIV. Research shows that the receipt of the old age pension is gendered. Women are more likely than men to receive it, and therefore are more likely to support extended families and to experience the stresses that are associated with that. The provision of support within families is not unproblematic and can become unsustainable in the face of comorbidities, frailty, and the need for medical and social assistance. If families are unable to provide support, they may turn to existing HIV treatment infrastructure to meet the needs of people aging with HIV. Our results suggest that stigma may limit uptake and that strained resources may not be able to accommodate additional demands. The continued burden of reduced income due to retirement, poor health associated with HIV and other comorbidities, and the continued demand for support and care from families require broader socio-political and economic changes in countries such as South Africa to buffer older people living with HIV. Thanks very much.
Thank you, Catherine. I had a parallel chapter in the book that was more quantitatively based. And Catherine and I were kind of amazed when we looked at the two together how reinforcing the findings were both from a qualitative and a quantitative lens. One of the things that Catherine was talking about was something that my mentor, Marge Cantor, was very interested in about support preferences and where do older people go for support. And she developed this hierarchical compensatory theory of support. And according to that theory, you turn first to those people closest to you, your immediate family, partners. And it's in those situations where they're either unable to meet your needs or unwilling to meet your needs, you start moving out into your network. So friends and neighbors, community organizations. And really, I think there's a parallel finding between what we've seen in the United States with people growing older with HIV and what we've seen in Africa, is that there are so many needs that there's going to be a greater reliance on community-based and government services, which is a real conundrum in both regions. And Dr. Finkelstein will be speaking a little bit to that. But first, we're going to turn to Dr. Kiplagat, who's going to talk about HIV prevention and service provision for an aging epidemic.
Thank you, Mark, and thank you everyone for coming. So this is chapter 9 of the book. It was a chapter that was inspired by my work during my PhD. I did my work in Kenya, the western part of Kenya, in a program called AMPATH. I managed the research program component of it. It is a program that takes care of over 90,000 patients on ART. We profiled older adults living with HIV and compared them with younger adults, and noted that this population contributed to about 12% of the HIV population that we were taking care of. And the key to the profile was that they actually come into care late into the HIV infection. And definition of late here was the WHO stage 3 and 4 with low CD4, high viral load. And we then went ahead, as this was really, the groundbreaking data that we were looking at the time. No one had done anything on HIV. We looked at the data and, to identify why are they coming into the HIV clinics late into the HIV infection. And we noted that one, services towards messaging of HIV was very low among older adults. They did not perceive themselves to be at risk. I think a lot of that has been discussed by the previous chapter authors. But then we also went ahead to look at what are some of the challenges that they face when they actually seek HIV care services. So the chapter does summarize the challenges that this population go through, and one of them is that they lack targeted HIV prevention messaging. And as such, they perceive themselves to continue to not be at risk of HIV. Ageist and discrimination is very common within our environment, particularly for older adults living with HIV. We also have high prevalence of comorbid condition. And in our healthcare setting, particularly in Kenya, we have verticalization of services. We have HIV care services being provided differently from other comorbid conditions like hypertension, diabetes, and all. Beside that also, it has been discussed by previous authors, is the lack of, or limited social support. It is very common back in Kenya too. Again, due to prevalence of comorbid conditions, we have polypharmacy, which results from the medicine that they take as a result of comorbid condition. So in this chapter, really, we call on policymakers, we call on communities, we call on HIV programs to relook at their service provision and tailor the services to meet the needs of older adults. We outline the following specifically in relation to HIV prevention. One, that the policymakers need to target HIV messaging to include older adults. It's no longer, the key population, the pregnant women, the younger adults, the children. Older adults need to be included in the communication on HIV messaging. Two is that we need to create awareness as well within the community avenues, faith leaders, churches about HIV and HIV prevention in aging population. Three is that healthcare providers also need to provide further education when they're providing services for sexual and transmitted infections. And that should include the HIV as well, because I think because you're older, because you're in the menopause, then you no longer fit within the reproductive health services. On the HIV testing and screening, we feel that, and we describe in this chapter that the targeting older adults will no longer require healthcare providers waiting in the facilities. That we need to go into the communities and look for these people, identify them, or offer services as near as them, especially the testing services. Again, we call on the programs to build capacity among the healthcare providers to understand sexuality in older age, and as such, provide sexual services for older adults. We also do, within the comprehensive care management, require that routine screening for comorbidities be done among the older adults so that we identify this early and manage it early before we actually really see a lot of, the end effects. Management of polypharmacies, so this calls for integrated care and multidisciplinary approach so that we can prescribe medication for these patients too. Continuous improvement of patient-provider communication, and this was also informed by the preferences of older adults, needing an older person or an older healthcare provider. Same sex was one of the preferences that they required here, and calling on healthcare systems to provide that if available within that system. Expanding the services within the community level, I did mention that, including the community ART and pre-fills for the meds. Reduction of the social isolation and strengthening social support is something that we also just call upon. Food and nutrition insecurity is very common, and we ask that that be supported, especially with the social support that we do provide for older age. Although that is provided for people who are 70 years and above, we feel that would still just meet even at a minimum. And tailoring, one other thing that I think is very key and we haven't talked about, or none of the others has talked about, is including older adults in clinical trials, determining the dosage, determining, the drug use for patients or for older people who are living with HIV. One last point is we call on, the policymakers and the healthcare systems to provide also capacity building in geriatric training, which is not a common thing in Kenya. We provide internists with care, but not geriatric training. Thank you.
Thank you. So I find it very interesting that given the differences between Eastern Africa and the developed world, the United States, there's still the same issue of older people who are infected with HIV presenting late for treatment. And unfortunately, this means that a lot of damage has been done to the immune system by the time people get on the therapy, which has long-lasting consequences. So now, our next speaker, our next author is Dr. Finkelstein, who will be talking about Beyond a Politics of Care. Ruth.
Thank you, Mark. First, before I forget, I want to acknowledge Greg Gonsalves and Mark Brennan-Ing, the co-chapters on this section. Greg is up at Yale. If you're on Twitter, you probably read Greg a lot. He's an epidemiologist and has been involved with infectious diseases starting in sub-Saharan Africa 20 years ago. And a high point of a long, hot summer were the interviews that the three of us conducted among direct care providers, people living with HIV, and policymakers across the region, and then the very active conversations among the three of us. I'm gonna sort of flip the lens for a minute and talk about older adults in sub-Saharan Africa and the infrastructure that exists for older adults, big picture, which gives some context and perspective on what is present and what is missing for people with HIV, because in a sort of irony, the focus of international giving and aid organizations on HIV in sub-Saharan Africa means that as dire as the needs are that have been described by the colleagues in this report, these are among the best served older adults in sub-Saharan Africa. So let's make the context here explicit. If we think about the subcontinent, it is the last to the phenomenon of global aging. In 1915, there were estimated to be 46 million older adults in sub-Saharan Africa, but like the other regions coming late to the phenomena of population aging, the increase is the most rapid. So that population is projected to triple to 156 million by 2050. So the issues that people have identified and that I'm raising today are growing in urgency rapidly. But the fact that currently older people represent less than 10% of the population, and the environment is one where choices have been made about the allocation of resources to support the health, social services, and economic well-being infrastructure, it's not shocking that this infrastructure is lacking for older people. But I want to say from the outset that these are political choices and they are not inevitabilities. The subcontinent does not need to underinvest in human capital, and there are examples of that repeatedly in different governments that have arisen in different countries at different times. There are currently several examples. South Africa is one of them, and there are a number of others. So it is not that it is impossible to meet these human needs in the subcontinent. It's that there are political and policy decisions made about how resources will be allocated that fail to meet them. So what are to me, the three main components of the basic human right to age well? And this is not just to me, but to, other small entities like the UN, the WHO, I've got company in this one, are economic security, universal health care, and social support. And in each of these instances, while the assumption is made on the subcontinent that these will be provided within the family and the community context, that assumption, scholars show, has never been right. And it only grows more wrong with globalization, the increasing wage work of women, and the urbanization of the subcontinent. So in terms of income support, this is that basic idea that after you can't work anymore, there is a pension available to you from your employer or from the government. every country in sub-Saharan Africa has some pension support on the books. But according to the International Labor Organization, the effective coverage of said pensions is roughly 15%, 1-5, of the total population. What's the main reason for that? It's not a big mystery. It's because of informal and subsistence labor. So the people who have a pension are those who had formal sector jobs, which is true here too, by the way. But the proportion of the population in the two kinds of employment are flipped, so that the majority of people are not eligible for pension despite the existence of a pension scheme in, on the books. Furthermore, pensions are extremely low. The South African case is the highest monthly pension on the subcontinent, not surprising. But the level of pension assumes familial support continues. It's not conceptualized as being enough to live on. It's imagined to be a contribution into the family pot. But what we know is that family structures are changing, and the inputters into the family pot all over the place are getting different than they were. And in families with HIV and AIDS, we know that some families are missing specific members of specific generations to be contributing to that pot. I want to say that women, particularly single women, widows, childless women, are the ones that are the most impacted. In terms of healthcare coverage, the kind of, I don't know, it feels to me ironic and sad that people living with HIV can get HIV treatment, but not the rest of healthcare. So as has been mentioned in several chapters, the system is very verticalized. I thought that was a nice diplomatic way to put it. But the fact of the matter, we think we live in a fragmented healthcare system in this country. In many of these countries, the healthcare system is fragmented by who is the international donor providing this piece of care and what are they interested in. So here is where childhood vaccination occurs. Here is where HIV treatment is available. Here is where there's some level of primary health care. And for people living with HIV who are older, and for everybody else, it is not possible to navigate that fragmented system. It first requires a huge amount of information that is not well disseminated, and then resources, access, and ability. The last point I'll make, because Mark is making the universal symbol that I don't think means home run, I think it means something else. I'm not sure what it could mean, is about social support, and to say that the government systems that provide assistance with transportation, with food, with case management, with caretaking, with housing are in their infancy. There is a pan-African myth of filial piety and that we take care of our own. Anthropologists and other scholars have disrupted that myth for years and years, but nobody is confused about the fact that if it was ever true, it can't be true now in the context of the global economy. So what we have is belief that a way of living will result in adequate care for all the generations, with a reality of an economy that precludes that from being true. So I don't want to end on a doom and gloom note, though I do want to end, to say that one of the many strengths on the subcontinent is in the strong activist base that grows out of the HIV community and other advocates for health and social access. And that one of the lessons from this pandemic is an understanding that without addressing the social determinants, which is what these are, health is impossible regardless of how many vaccines we develop.
Thank you, Ruth. So now we're going to the moderated discussion portion. If this is really the first time a lot of the authors have been in the same room, even if it's a Zoom room together. So a chance for a little exchange between the authors, and then we'll turn it over for a more general Q&A. For those of you joining us virtually today, if you put your questions into the chat, Jenny is in the back of the room and in the Q&A function. Put them into the Q&A function, and then we will address those questions later. So for the panel, I'm going to move over here and sit down. But any questions for each other, any reflections on some of the other information that's been presented today?
Mark, I had a question.
Please go ahead.
Oh, okay. I wanted to ask Cherry specifically about how to provide more efficient HIV services in the community. I know in the chapter there was some discussion about what's called community art groups, and I was wondering if she could share a little bit more about those community groups, the peer model, and what's known about their effectiveness.
Thank you so much, Kristen. So the community ART groups have that kind of model has been tested in Western Kenya, not for all the adults though, but this was tested for the adult population. In this model, we had community health volunteers who were stationed in the community. And what they would do is they have a number of patients who've been assigned to them. And these are patients who do not, they're on what we call express care. Really, they're stable patients. They don't need to come to the clinic on a monthly basis, and they could get drugs on, after every 3 months. So rather than, there is also an issue of drug supply sometimes. So you may get drugs for, say, a month, but rather than you come for the next month without really seeing a clinician, we have a community health volunteer who would come over, pick all the drugs for the patients and supply to them at a specific area. Beyond that, we have what we call group. It's developed. We call them GIS. It's group integrated for empowerment, for economic empowerment. Those are groups where you have members of the community form, what we call chamas. Chamas are sort of merry-go-round. they contribute some amount and they be part of the group, sort of just then that becomes something that ties you to the group. And that can be an opportunity for where drugs can be picked up. It is an opportunity for where a healthcare provider can go into the group and offer services in the community and for the group members. At times, the group members may or may not all be HIV infected, but at least could be part of the community groups. I don't know if that is helpful, Kristen.
Thank you so much.
I have a question for Dr. Bernard. We've been very concerned about mental health issues among older people with HIV in this country for many years. Despite the greater resources we have here, it really seems like things are unmanaged when you look at the rates of depressive symptoms and things like that. When I talk to people in the community, I think because they're on their HIV medication, they're on a lot of other medications for comorbidities, they're really interested in non-medical approaches to managing depression and other mental health problems. Could you speak to that and any work that's been done in Africa on that topic?
Yeah, I think it is an important point, and we have in Senegal, in West Africa, we have an ongoing studies on interpersonal therapy. It is a therapy recommended by the WHO, and it is in 8 sessions per 1 session per week during 8 weeks. And it is the approach is a psychotherapeutic approach. So the aim is to avoid another medication, and particularly antidepressant medications, and it works well. And it is also an important point because just before we talk about the effect of groups, and this therapy is administered by groups, and it is very relevant for the patient because it is important for social support and to fight against social stigma and so on. But by now, there is also other psychotherapeutic interventions in Uganda. I think about the works of Nakimuli Pungu and our team, who are very interesting. It's also in group, and I think this is the future of, because it is very useful for the patients to break isolations and to share with their peers about their experience and so on. But they are not focused on aging and the problematic that you can have when you age. So maybe we will have to think about how to address it.
Thank you. Yeah, I think that social component is so important because so many of these mental health issues really have their basis in social isolation and related stigma and things like that. Do we have any other questions, comments from the panelists before we open things up to the audience?
I just wanted to sort of add to what Dr. Finkelstein had said about the issue of not having defined geriatric care in most sub-Saharan African countries. You know, like I think that's also like obviously such a political thing, and as far as like being able to define that as a you know, a specialty that individuals need to focus on. I mean, we have ministers of youth, we have a lot of many focused things that are like directed towards sub-specific groups. But when it comes to the elderly, there is not, you don't find that quite defined sort of structures that are like, or health structures that are like, you know, focused on this particular cohort. That in itself, like we always find that we define that within a disease, like whatever infection that you're dealing with, whether it's HIV, then it's going to be like HIV care amongst the elderly. So that is going to be very hard to sort of create and sustain because you do not have a base, a foundation of what geriatric care is when you don't have that already defined within systems. So I think that also, that is one of the root cause of a lot of this neglect that gets to happen at a medical standpoint, and that also now ends up infiltrating to the social aspect of things, in as far as like talking about elderlies being elderly individuals being most of the time looking after their families and being breadwinners, while also at the same time, when you're looking at the issue of pensions, you're looking at someone having to get pension at the age of 65, and which is what it will be defined as an elderly, and that's when an individual qualifies to get the pension. But then the thing is, then what happens to those people that are between the age of 50 and 65? When you talk to them, when you do studies and you talk to them, it's always a feeling of despair and feeling like they're completely neglected. No one is thinking about them. And yeah, so I just wanted to sort of like add to that.
That's a great point, Cabo. Here we've talked a lot about how important geriatricians could be to treating older people with HIV. But in this country, we have a shortage. I think there's less than 12,000, and that number keeps going down every year. And that has more to do with the economic incentives to be a geriatrician. It just does not attract a lot of people into that. I've done some work with Dr. Jeannie Siegler at Cornell and Meredith Green at San Francisco General about, given the shortage of geriatricians, could we take principles of geriatric care and somehow infuse those into HIV practice? And that might be a more feasible alternative. I think right now we'll turn it over to questions from our in-person audience and virtual audience. Sure. Yeah.
Hear me? So yeah, I was just a little bit curious about the HIV, like the older adults, they contracted HIV when they were older or they grew up with HIV. That was one thing that I was interested if you looked into. And then the second thing, which I feel like is like I'm not blossoming, but like a new area of research is how climate change impacts aging. And that's something that I'm particularly interested in. And I feel like especially in Africa where climate change is having a greater impact that we're not really talking about. I was just curious about if you guys looked into how HIV was being impacted by climate change or like HIV care. Sorry, that was like long-winded, but yeah. Thank you.
I can respond if that's fine. I can respond on the first question. I think, and I think that 2 or 3 panelists have responded to the point that HIV, older age people are at risk of HIV infection, but they are unaware of this situation. In the tradition says, and I mean, when you talk to people here in rural Africa, people over 50, the belief is that they are not sexually active. So far, they are not at risk of HIV. But we see that this belief goes together with less use of preventive measures. Many of them still have 2 or more partners in the last year. And the incidence, the new infections are relatively high for the age. And in a study we did, it was like 0.4 for 100 person years, which is relatively high, and was double in women than in men, all at this all age group. Then I think that all the people, although with ARTs, they are growing and they're getting older with HIV infection, we have to be aware that there are new infections and older people are also getting infected of these old age groups.
In relation to climate,
Oh, no. I was just going to add in the case of Botswana, for instance, if you have as addition to, like the cohort of older people living with HIV. I mean, a lot of people have been living with HIV for a long time, and they have transited into adulthood with HIV. So then, I mean, that is reflected in the recent statistics, which actually shows that the prevalence has increased to like 20.8, the national prevalence. And then when you look at the elderly population, you're talking about 21% of the people. So then realizing that a lot of, and that's like the people that are over the age of 50. So, but then when you look at the particular age of people between the age of 40 and 50, that's even bigger. So then you know that in the next decade, you're going to have even a larger population of that, because people have been, the epidemic has been going on for a long time and people have been on medications. And then because the tendency is when we have achieved viral suppression, we tend to think that everyone is now at an equal footing, instead of actually just having to not realize that as people grow, then there are other complications that do happen, that happen despite, without HIV. So then when that comes in, then there could be some complication, which is actually shown under COVID. It will be very interesting to see what the statistics will be like for individuals that way. They might not have been immunocompromised, but then living with HIV and many other comorbidities, as to how many like that led to a lot of people possibly dying. Something like that.
And we did a chapter on sexual behavior in the book that we didn't talk about today, but we found that older people are sexually active, particularly if they have a partner who's available and they're in good health. They tended to use condoms more with casual partners than with regular partners, which then does put regular partners at risk. I think I have a colleague from Kenya, an older woman with HIV, and she tells a story about going to a health clinic for sexual health matters and to get condoms, and they were very rude to her and said, "You're too old to be doing stuff like that." So it's, this all feeds into this idea of older adults not being sexually active and not being at risk for HIV and other STIs.
Yeah.
I just want to loop around to your climate change point. I am unaware of research tying aging, HIV, and climate change together, but I can put two of those points together, suggesting to you that you read an article by Vigard Skurback, who did mapping of regions at risk for early harm due to climate change in relationship to proportion of their populations that are aging. So I think even in high income contexts, we are seeing now daily the consequences of storms, which is only one manifestation of climate change, and they're always disproportionate impact on older people for a whole series of reasons having to do with information, with ability to follow the directions that are in information, reticence to do so, and economic ability to rebuild following a disaster. So I think this may be part of the contribution you'll be able to make.
Jenny, do we have any? So the question is, how does the rural-urban divide affect mental health, stigma, access to services? Is that and social support and social networks? So anyone on the panel would like to take that?
I can try to answer some of it. We don't have the information, or I don't have information on older population per se, but I know that in a study that we are doing on migration from rural to urban areas here in South Africa, together with the University of Brown, we have seen that people that move to urban areas from rural areas, they have less support, less networking, and more difficult access to health services. Even you will think that it's the opposite on the health services because the health services are closer, but they are accessing them. It's more difficult for them because they are not so familiar. And then people, when they get sick and they need support, they come back to the rural areas to get this support. And what it happens in this situation, and that we are experiencing in this rural area of Northeast South Africa, is that people are coming back home when they are sick, creating an extra burden in the already weak health services. Then we have the older population that if they have been in urban areas, now they are sick, they come back and they're asking for support in the families in the rural areas, and they are asking the health systems in the rural areas that have less resources to treat them and to look after them. Then, that's what we are experiencing in these rural areas in South Africa. But maybe other panelists have other experiences.
I think the other thing possibly to add is that, there's often the perception that a move to an urban area is because there's employment and because people have opportunities, but actually often, and I can't speak to older people specifically here, but I think often people move to urban areas with nothing. And so they actually are putting themselves into greater poverty than they may have been in a rural area. And so, as Xavi said, lack of information, lack of access, but also poverty and the compounding impact that has on your access to healthcare, and lack of social support to access that healthcare. So I think it's important to see that migrants to urban areas are not always successful people going to take up jobs. They are often people who are driven by desperation, and so they're moving into really poor, low socioeconomic areas, and are marginalized within those urban areas.
And I might suggest the work of Isabella Abodran, who writes specifically about Nairobi migration to urban slums in Nairobi, internal to the country, and writes about older adults and actually intergenerational connections in this context to that person.
Next question, Jenny.
Can you hear me?
Yes.
So Beth Summers says, many thanks for your scholarship and commitment to health. And she has two questions. One is about health and wellness throughout the life cycle. Wellness has dimensions of mind, body, spirit. Could you comment on your findings related to this? And then later she asks also about the role of traditional healers, which may be tied in to that question.
So can you repeat the first question about the life cycle?
She says wellness has dimensions of mind, body, spirit. And this is a question about health and wellness throughout the life cycle. So could you comment on your findings related to this? The other dimensions of wellness.
Mark, I might be able to add something about religion association, which might tie in a little bit to Dr. Summers' question. My chapter, although I didn't present it today, looked at caregiving among grandparents with HIV. And one of our hypotheses was that religious attendance would actually show a stress process buffer effect in the impact and the association of depression. And in fact, that was not found But one of the reasons that we think that was not found was that religious attendance had no significant association with depression because there was such little variability in the sample, given that the importance of religion was in fact universal. So at least in those data that my group evaluated, we weren't able to really tease out the role of religious attendance or spirituality in that way.
Thank you, Kristen. And what was the second part of that?
It was, what is the role of traditional healers in sub-Saharan Africa? If there's any research on that.
I believe there is, but I don't think that was covered in the book.
No, it was, I didn't mention that in the chapter. We have some initial studies, and I know that it has been done in Mozambique, and now we are replicating here in South Africa on the not integration of the traditional healers into the Western treatment, but for them to learn how to test and accept how to test for HIV to their patients. And this is something that has been well established in Mozambique, that the traditional healers are very willing to learn how to test and do rapid tests of HIV, and then be able to refer HIV people to the health facilities. And here we are starting to explore that. And we saw that the previous to that study on training them, we saw that traditional healers, they have higher levels of HIV. The prevalence is higher than the population, possibly because of the ways that they are treating their patients with CARDs and other exposures that they're having. And the first thing was to diagnose them and to refer them and to treat them. But I mean, I don't have any study on how they are treating HIV patients and if they are doing it independently from the primary health care.
So, in some data, and I can't place the author very well, but this was done in the coastal part of Kenya, indicating that older, and this was specific on older adults, that older people, beyond seeking, the contemporary HIV medication, they would also visit traditional healers. And in some cases, that has really worked to their detriment, in that they've gone to seek care within, the traditional healer environment, and they abandon their ART. And being told by a traditional healer that you're now healed, you no longer have HIV, 1 year or, way later when they are really sick, when they've, when they have all the AIDS symptoms, they're coming back into care for their HIV. And one of the calls they were, putting out there was that traditional healers can be an avenue for education and educating not only older adults, but the general population about HIV, that beyond the medication and concomitant medication, both for traditional healing and HIV medication, could have side effects, could have interactions. And as such, educating traditional healers to understand the HIV and how HIV infection works, their understanding on when they are seeing patients who have HIV and how they can manage them with the traditional medication and all, is very helpful for the know-how for them, and also for them being able to advise the patients themselves on how to seek care within the care facilities rather than within the traditional healers themselves because of drug-to-drug interaction issues.
Thank you. Well, I think that just about takes us to the end of our time today. I don't know if we go back to the slide or not. For those of you in attendance, both in person and virtually, the publisher of this book, Springer, has offered a 20% discount on both hard copies and ebooks. Here's the discount code, but we will send out this flyer to everybody that we have an email address for. So you don't need to scribble this down right now. You'll get this in your email soon, hopefully in a few days. I'd like to thank all of you for coming. I'd like to thank our panelists, particularly Cabo and Catherine, who are Zooming in from Australia, where it's now very early Thursday morning, but they were happy to come and be on the panel and seem really awake and perky. So thank you. And for those of you here in person, we do have a little reception upstairs, so we hope you can join us for that. So thank you so much, panelists, guests. There's some really great information in this book. I'm not just saying that because I worked on it, but all of us who worked on this really feel that it's bringing some important information and attention to a population that's really neglected of older people with HIV in Africa. So thank you all.